Welcome again to lectures discussing nephrotube synopsis of conventional hemodialysis first edition. In this lecture we will start discussing venous catheter use, and we will cover basics and care of venous catheter use. Before I go through the lecture, I want to mention that in this chapter in the book I used the terminology venous catheters and also the terminology central venous catheter. I used both of them. Both of them are the same, but I used them according to how they are mentioned in the original reference. In the description of this video in YouTube, below the video, we will find some important links. The first link is a link to this same lecture, but in Arabic language, for those who like to watch the lecture in Arabic. We'll find also a link to the playlist of video lectures about this book. You will find the link for the English playlist and Arabic playlist. We'll find link to download this book for free. You'll find link to download the PDF of this lecture for free if you like to use it. You will find a link for my website nephrotube, nephrotube.com, where you will find more lectures about nephrology than hemodialysis lectures. And finally, you will find a link to nephrotube social media accounts, the WhatsApp group, the Telegram channel, the Facebook group. You can join us to be always updated by the activities of nephrotube. And finally, it's better to subscribe to our channel and to make the notifications on from our channel, so you will be notified once we upload new lectures. This is my talk outline, and I will start by indications for venous catheter insertion and use. First, insertion of venous catheter for dialysis is indicated in patients with acute kidney injury requiring dialysis, in patients with intoxication or overdose requiring dialysis, and in patients requiring plasma exchange. So these are the indications for the use of venous catheter away from patients with end-stage kidney disease. Patients with end-stage kidney disease may require or need insertion of venous catheter in some situations. First, if there is a patient, an end-stage kidney disease patient who requires urgent hemodialysis, but the patient has no available mature access, arteriovenous access, as AV fistula or AV graft. Also, as we mentioned in the previous lectures, where we discussed the arteriovenous fistula and arteriovenous graft, we discussed that in end-stage kidney disease patients with limited life expectancy, the choice of dialysis from venous catheter may be a reasonable choice. As we mentioned, that the concept of fistula first is not the one used now. We are now using what is called patient first. So there may be an indication for the use of venous catheter in patients with end-stage kidney disease, especially those with limited life expectancy. You can refer back to the previous lectures about AV access to check which access is indicated in which patient. Also, the use of venous catheter for hemodialysis is indicated in end-stage kidney disease patients with any AV access related issues, as infiltration of an already formed AV access or cellulitis, prior multiple failed AV access. The patient has heart failure with ejection fraction lower than 15%, which is a clinical condition that could be worsened with AV access creation. So in this patient, we cannot create AV access, and it's better to dialyze from catheter. If the patient has his own choice to dialyze from central venous catheter, or in patients where central venous catheter can affect the quality of life of the patient, and the patient preferred to use central venous catheter, and also it can be used in patients with needle phobia. Also, venous catheters can be used in patients on peritoneal dialysis and end-stage kidney disease patients on peritoneal dialysis with complications as peritonitis, for example, and the patient require time-limited peritoneal rest till the resolution of the complication as peritonitis or pleural. So in this situation, we will shift the patient from peritoneal dialysis to hemodialysis till the complication is resolved. Also in transplant recipients who also have complications as rejection, there may be a need for temporary hemodialysis till the treatment of this rejection or other complication. So in all of these patients, venous catheter insertion and use is indicated. The next point is the comparison of the use of venous catheter versus the use of AV fistula and AV graft. In general, Care-Dr.Gawad Vascular Access Guidelines 2019 mentioned and suggested that the use of AV fistula and graft in preference to central venous catheter in most incident and prevalent end-stage kidney disease patients. And they suggested that the use of catheters in these patients should be converted to either AVF or AVG if possible. But again, I have to remind you that this depends on the life expectancy and life plan of the patient, as we mentioned before in the AVF and AVG lectures. So why in general AVF and AVG are better to be used than central venous catheters? Because complications and vascular access related events are lower with AV access as AVF and AV graft than the use of catheters, and for sure, as we mentioned before, that the complications are lower with AVF than AVG, as we mentioned in previous lectures. Now we will go through venous catheters types. What are the different types of venous catheters? We have two types. The first one is the tunneled cuffed catheter, which we call it permacath, and the other one is the non-tunneled uncuffed catheter. Which one to be used? The Care-Dr.Gawad Vascular Access Guidelines consideration for patients with end-stage kidney disease who require and are indicated for venous catheter insertion. The Care-Dr.Gawad preferred the tunneled catheter than the non-tunneled. The tunneled catheter, as you can see here, it has what is called Dacron cuff. This cuff provokes local inflammatory state, and this local inflammatory state in the tunnel of the catheter will cause fibrosis and inflammation, which make the catheter more fixed in the tunnel and prevent migration of bacteria from the skin into the subcutaneous tunnel with lower risk of infection. So in patients with end-stage kidney disease who required central venous catheter insertion, it's better to use tunneled central venous catheters. The use of the non-tunneled central venous catheters is mentioned by Care-Dr.Gawad. If you will use it, whatever the reason, as I will mention later, should be used temporarily for a limited period of time, less than 2 weeks. Why? Tunneled catheter is preferred than non-tunneled catheter because, as I mentioned, it has lower risk of infection. This regarding the Care-Dr.Gawad recommendations for patients with end-stage kidney disease. Regarding the Care-Dr.Gawad acute kidney injury guideline in 2012, regarding patients with acute kidney injury, they mentioned that to initiate dialysis in patients with acute kidney injury via uncuffed non-tunneled catheters rather than the tunneled catheters, as it is supposed that you will use them for short time. After we mentioned venous catheter types, we have to mention now the venous catheter tip design. The tip of the venous catheter can be found in different shapes. These are the different shapes that are available, especially for the tunneled venous catheters. Here is the split tip with curved tips, the split tip standard tips, and so on. Maybe the most famously used in many of the areas is the symmetric tip with side holes. And this is also the common shape for the non-tunneled venous catheter. So all of these, you can find them in the tunneled venous catheter. And this shape, you find it commonly in the non-tunneled venous catheter. Let's go through this shape more. In this shape, you will find, if you took a longitudinal section in this catheter, you will find that there is side holes for blood entry from the venous blood of the patient into the catheter. Then this blood will go to the hemodialysis machine to be dialyzed. Then the blood will be back from the tip holes to the patient's vein. If you took a transverse section in this catheter and we look about it, you will find that it is in the form of double D-shaped. One side for the blood entry from the patient and one side for the blood to return to the patient's vein. Okay, next, what about the insertion location? Where should I insert the catheter? In the internal jugular vein, in the subclavian vein, or in the femoral vein, or others? Let's talk about the insertion locations first for the tunneled cuffed venous catheters for end-stage kidney disease patients. The Keduki Vascular Access Guideline 2019 update mentioned that it's better to insert the catheter in upper extremity before lower extremity vein. So it's better to be inserted in upper extremity neck veins. And it is preferred to insert the catheter in the right side than the left side of the upper extremity. This is because the course from the left side is too long to reach the heart by the catheter, but from the right side it is easier and shorter course without much angulations to reach the cardiac chamber, the atrial chamber. That's why the right side is preferred. And it is important. So again, in the absence of any contraindications, the right side is preferred than the left side. Okay, but if there is any, and this is an important point, if there is one side has pathology that limits the creation of AV fistula later or AV access later, but this side allows catheter insertion, so please use this side to preserve the other side for AV access creation. So if you have a contraindication for AV fistula at one side, let's say the right arm, but at this side there is no contraindication for venous catheter insertion, so please use this side for catheter insertion. Another important point to put in mind that the choice of location may depends also on the duration of use. If the duration of use of the catheter is expected to be less than 3 months, so use upper extremity venous catheter. Okay. If the patient is anticipated to have AV access within these 3 months, so use upper extremity central venous catheter in the opposite arm to the anticipated AV access arm. And if the patient is expected to have transplantation within these 3 months, so please use right internal jugular catheter or upper extremity catheter and avoid femoral catheter, because femoral catheters may affect iliac vessels and we need to preserve iliac vessels for the anastomosis of the transplantation. Some experts support that if the duration of the catheter use is expected to be less than 1 month and transplantation is not an option, they suggest to use femoral tunneled catheter to save the upper extremity catheters for the creation of AV access. But for sure, femoral vein catheters have a lot of complications and also contraindications. Femoral tunneled catheters, or whatever, femoral catheters in general, are contraindicated if there is any femoral or iliac vessel pathology, if there is hygienic reasons as chronic unresolved diarrhea, morbid obesity with a body mass index more than 35 kg per meter square, and if there is any difficult femoral vein access. If the duration of the catheter use is expected to be more than 3 months without any anticipated use of AV access, tunneled cuffed catheters may be placed in the following order. So now it will be the permanent access of the patient in this situation. The patient will not have any AV access. The first location is internal jugular, followed by external jugular. I didn't see that much catheters in the external jugular actually, but these are the recommendations of the Keduki vascular update guidelines. Then the femoral, then the subclavian, and finally the lumbar access. So now we discussed the location of tunneled cuffed venous catheters in end-stage kidney disease patients. Let's go through the non-tunneled uncuffed venous catheters for AKI patients, as it was mentioned by KDIGO acute kidney injury guidelines in 2012. They mentioned at first that the right internal jugular is the preferred side. We mentioned again the right is preferred than left because it's shorter and straight course. Then femoral, then left internal jugular because it has a relatively long and twisty pathway to the right atrium. Then subclavian is the last option because it has high incidence of insertion-related complications and high incidence of central venous stenosis. Okay, now after we discussed the insertion location, what is the accepted catheter lengths? Catheter lengths differ according to catheter location. For example, let's talk about the accepted lengths for tunneled catheters. Regarding the right internal jugular catheter, the worldwide range is between 19 and 31 cm with a size of 14 or more French. Left internal jugular worldwide range from 23 to 36 cm. Right femoral from 36 to 55. Left femoral 55. For sure, the femoral length is longer than the jugular length because in the femoral, as we will mention later, we need the catheter to reach the vena cava. So why it has a longer length. Regarding the non-tunneled catheters, right internal jugular length is between 20 to 15 cm. Left internal jugular between 20 and 24, right femoral 20 cm, and left femoral 20 cm. And you have to notice also that the length of the non-tunneled catheter is somehow shorter than those of the tunneled, because as I will mention later, the catheter tip position. You will find that, for example, for the right and left internal jugular, we need the tip to be in the right atrium. But in the non-tunneled, we need the tip to be higher than in the tunneled catheter. We will mention this later. So let's talk about the tip position. And by the way, in my book, I discussed in details the insertion technique. I will not discuss it in this lecture because I believe that insertion of the catheter is not a matter of slides or photos, you have to be trained by your seniors in your unit about how to insert the catheter. So I wrote it in my book, yes, the insertion technique, but my advice to be taught the right insertion technique, you have to see this in your hemodialysis unit. About the catheter tip position and the placement, you can see here two photos, two x-rays, one for right non-tunneled internal jugular catheter and one for right tunneled internal jugular catheter. Please notice that the tip of the tunneled catheter is deeper than that of the non-tunneled catheter. We need in the non-tunneled catheter, or let's say first in the tunneled catheter, we need the tip of the catheter, whatever it is, internal jugular as this photo or subclavian, to be in the right atrium if the patient is supine position, and for sure as the patient stands up, the catheter will retract it about 2 to 4 centimeters up. But in the non-tunneled catheter, it should be positioned at the cavo-atrial junction, because the non-tunneled catheters are more stiff, and this may increase the risk of complications if they are placed in the atrium. Regarding the tip of the femoral hemodialysis catheter, I didn't show any photos for it, but regarding the tip of the hemodialysis catheter, whatever it is, tunneled or non-tunneled, it should be placed in the inferior vena cava. Regarding insertion-related complications, what are the complications related to catheter insertions? Let's talk about complications related to all catheters, whatever internal, jugular, subclavian, or femoral. The first is arterial puncture, and this is common, by the way. That's why in the insertion technique, it's better to use small gauge needles at first. So if you did any puncture, it will be of a small size, and it is important to make a local pressure, uninterrupted pressure, for about 15 to 20 minutes for any arterial puncture to avoid the development of hematoma. The second complication that may be related to insertion of catheters is accidental arterial insertion of dialysis catheter. It is very rare, but it happened before, and in this case you will find the color of the blood in the hemodialysis circuit very bright. It is the arterial blood. Dialysis should be stopped, and you have to get surgical opinion to avoid major complication and tracheal compression if this catheter was an upper extremity catheter, because when you remove the catheter from this artery, it is possible to have a large hematoma. And if urgent dialysis is needed in this patient, you will remove the catheter from the artery and put a new catheter in another vessel, but start dialysis without any anticoagulation. Finally, air emplacement can happen, but it is more common for sure with jugular and subclavian catheters than femoral catheters. So these complications are related to all types of catheters and all locations. But there are complications related more to internal jugular and subclavian insertion. For example, pneumothorax, hemothorax, maybe arrhythmia and cardiac tamponade, perforation of the superior vena cava and cardiac chamber, and this is a fatal condition, by the way. It can be expected when there is unexplained chest pain by the patient, dyspnea, hypotension, and for sure surgical intervention is mandatory in these cases. Then there may be injury for any adjacent structure as brachial plexus, recurrent or injured nerve. All of these are rare complications, but they could happen. Going to complication related to femoral catheter insertion, which is also a fatal and very serious complication, which is retroperitoneal hemorrhage. It can occur if there is femoral artery puncture or accidental puncture of the back wall of the femoral vein. It can be suspected if there is abdominal pain and rapid decreasing in the hemoglobin of the patient, and it is diagnosed by CT abdomen. Okay, regarding catheter lock that we can use for catheters, and again, I skipped in this lecture the one of the titles in this chapter in my book, which is Central Venous Catheter Connection and Disconnection Procedure, because again, I believe that this is a procedure that you have to be trained in the hemodialysis unit itself, and I shouldn't cover it through the lecture, but you can read it from the book. Regarding catheter lock, why we are in need to use catheter lock, which is mainly formed of anticoagulant. Why we have to put anticoagulant in the catheter at the end of each hemodialysis session? The main goal of catheter lock is to prevent intraluminal thrombosis, and we will discuss in the next lecture intraluminal thrombosis in details. There may be a thrombus that can be formed intraluminal and obstruct the catheter. We have to avoid this by catheter lock. And also, catheter lock is important to prevent the formation of what is called biofilm. This biofilm is a nidus for bacterial formation, and will be a source for catheter-related bloodstream infection. So this can be avoided by the formation, by the use of systemic anticoagulation. Sorry, by the use of catheter lock. So the biofilm can be formed biofilm of bacteria, can be formed under this fibrin sheath, and this fibrin sheath under that can be formed around the catheter can be prevented by the catheter lock. Now what about catheter lock manipulation? After hemodialysis session, after each hemodialysis session, the dead space of each lumen is filled with the lock. You can find the volume of each dead space on the catheter tip here, sorry, on the catheter limb here. Inject the volume of lock solution. Don't inject a larger volume, because this will lead to escape of the catheter lock into the patient's blood, and we mentioned that the catheter lock is formed of anticoagulant. This will lead to rest of bleeding. Before each hemodialysis session, before starting hemodialysis, the lock in each lumen must be aspirated, and the catheter then flushed with heparinized saline or pure saline. Then you can start hemodialysis. What are the types of catheter lock? First, heparin or citrate. Heparin lock can be used in the concentration of 1000 or 5000 units per ml, and also citrate lock can be used, but citrate with low concentration of citrate, less than 5%, because high concentration of citrate can cause multiple side effects as hypocalcemia. The question now, which is better, heparin or citrate? There is no evidence or there is inadequate evidence to demonstrate difference between them regarding catheter survival or complication, so you can use any one available of them at your unit. Another lock I have to talk about, which is tissue plasminogen activator lock. The Kiduki Vascular Access Guideline 2019 suggested that TPA can be used in the following cases. In general, it can be used once per week to help to reduce catheter dysfunction, especially in patients in need for long-term central venous catheter who are at risk of crepsy. For example, patients with nasal carrier of Staphylococcus aureus, or patients with multiple previous catheter-related bloodstream infection, especially in facilities and units where the incidence or the rate of catheter-related bloodstream infection is very high, more than 3.5 catheter-related bloodstream infection episode for every 1,000 days. So now we use the anticoagulants, heparin citrate, tissue plasminogen activator. Can I use antibiotic or antimicrobial lock for the catheters? The answer is yes. There are indications to use antibiotic or antimicrobial lock. The first, it can be used as prophylaxis, again in patients with need for long-term catheter who are at risk for crepsy, especially in facilities with high rates of crepsy. And also it will be used in management of crepsy, as we mentioned later in the coming lecture. The question, which antibiotic or antimicrobial agent can used for catheter lock? Regarding the Keduki Vascular Access Guideline 2019 update, they mentioned or they support the use of specific antibiotics, cefotaxime, gentamicin, or cotrimazole. And regarding antimicrobials, they recommended or they supported the use of methylene blue. And they mentioned that they cannot support antimicrobials and antibiotics with very low evidence. But a recently published randomized double-blinded trial showed that the use of toluidine with heparin in comparison with heparin decreased the rate of crepsy and the incidence of crepsy, and decreased the event rates for every 1,000 catheter days. And also regarding safety at 200 days, both of them are comparable regarding safety. So there is a new evidence that toluidine heparin has a better protective effect regarding catheter-related bloodstream infection. Important points related to catheter dressing. First, about catheter exit site care, we will mention in the next lecture that there is what is called exit site infection, and this is very common. So exit site care is very important, starting by skin cleansing. Skin cleansing should be done at the end of every hemodialysis session. Cleanse the skin surrounding the catheter exit site with chlorhexidine, and if there is allergy from chlorhexidine, bovidine iodine can be used. Can I use skin ointment for exit site? Actually, applying antibiotic ointment or bovidine ointment to catheter exit site at the end of hemodialysis session is recommended. And you will find a lot of examples for antibiotic ointments that can be used. I mentioned in my book in page 167, but there is inadequate evidence to demonstrate a difference in these different ointments, except that in myopia, if you used a single antibiotic ointment containing mupirocin, the development of resistance may be high. But if you used multiple antibiotic ointment, there is inadequate evidence to prefer one ointment over another. But again, there is high concern about the emergence of resistance even if you used multiple ointment antibiotic. That's why there are other strategies suggested to decrease the incidence of this resistance. The Keduki 2019 update and the European Renal Practice Guidelines in 2010 suggested to use the antibiotic ointment only until the insertion site has healed, and not to use it with every session forever. Another intermediate strategy suggested that the use of the antibiotic ointment can be limited to patients with repeated episodes of infection. So there is recommendation to use the ointment forever, but these are intermediate strategies to prevent and avoid resistance. An important point to put in mind that there may be an interaction between the ingredients in the antibiotic or bovidine iodine ointment with the catheter. So please ask the manufacturer that you get the catheter from them about the possibility of the interaction of the catheter material with the ointment you are using. Regarding dressing type, which dressing type is better to be used? For sure, it must be sterile dressing. Non-breathable and non-porous dressing should be avoided because this type of dressing carries a higher rate of colonization, bacterial colonization. Regarding transparent versus non-transparent dressing, there is inadequate evidence to support any of them. You can use both of them. Regarding dressing frequency, for sure you have to change the dressing every dialysis session, but if your patient is not dialyzing 3 times per week or 2 times per week, you are starting, for example, incremental hemodialysis for this patient, so dressing must be with a minimum of once a week. Regarding dressing and wet environment, Kiduki mentioned that the dressing should be protected against wet and dirty environments, but if the patient insists on showering, so it's better to do the following. Showering should be done only after the exit side sinus tract has become established, and showering should be done before the patient comes to the hemodialysis unit, where the new dressing and antibacterial ointment can be applied immediately after the dialysis session, and we will remove the dressing that is exposed to water immediately before the hemodialysis session. Then, what about the duration of catheter use? For how long the catheter can be kept in place? Regarding the tunneled cuffed catheters, Kiduki mentioned that there is no maximum time limit, and it is not reasonable to use these catheters as long as they are functioning. And the overall survival of these tunneled catheters is highly variable, by the way, according to different studies. For example, there are some reports reported that the survival of these catheters and their patency ranged from 77 to 80%, 87% at 6 months, and also from 72 to 76% at 12 months. In one report, some patients had functioning catheters for 343 days. In another report, they are functioning and patent for beyond 2 years, and so on. Regarding non-tunneled catheters, the Kiduki 2019 mentioned that they must be used maximum for 2 weeks due to the increased risk of infection. And I want to highlight the Kiduki Vascular Access Work Group 2006 because they mentioned good points. First, they mentioned that non-tunneled catheters should be used only in inpatient settings. And regarding the non-tunneled internal jugular, shouldn't be used more than 1 week. And the non-tunneled femoral catheter no more than 5 days, and the patient should be bed-bound with good exit side care. I think it is more safe to be used than to make it maximum 2 weeks for all types of catheters. Finally, we have to mention that there is risk of air embolism on removal of dialysis catheters from the neck, and this may be lethal. So to avoid this, you have to follow the following instructions. First, no heparin should be used in the hemodialysis session on the day of catheter removal. You have to put the patient in a head down position during catheter removal and instruct the patient not to cough or inhale deeply during the removal. You have to use air occlusive dressing with a generous amount of inert ointment. And finally, you have to observe the patient for 30 minutes before leaving and leave the air occlusive dressing left in place for at least 24 hours. We finished this lecture about venous catheter basics, insertion, and care. See you in the next last lecture about venous catheter complications. Thank you.